Good afternoon. So what's new in the management of ACCs? We know that ACC is present in about the fifth and sixth decade of life, and predominance is in females. Majority present with a functional tumor, and most of them are cortisol secreting. A subset present with vague abdominal symptoms such as a mass or abdominal pain, and a minority are incidentally detected. Majority are sporadic, whereas minority are hereditary, leishmania being the major cause of hereditary syndrome. In pathology, we know that SF1 is the most reliable and specific biomarker for tumors of adrenal origin that are cortical. So if you have a non-functional tumor and you not sure whether it's cortical or medullary, then the IHC that is used is SF1. And traditionally, to differentiate benign versus malignant tumors, we have been using the WISE and the modified WISE scoring system, the score of 3 or more that indicates malignancy. So what's new? The WHO 2022 classification of adrenocortical tumors expands the use of other multi-parameter diagnostic algorithms to assist the workup of adrenocortical neoplasms. And these include the Reticlin algorithm, the Lin-Weiss Viscili system that is mainly used in the oncocytic neoplasms, and the Helsinki scoring system. It also underscores the diagnostic and prognostic impact of angioinvasion and highlights the role of IHCs and molecular markers for ACC. With regards to the multi-parameter diagnostic algorithms, the most popular is the Reticlin algorithm because of its reproducibility. And here, using the Gordon-Sweet silver histo stain, where there is a loss of Reticlin framework or an altered Reticlin framework, along with one of the following features, that is mitotic count more than 5 per 50 hyperfield, tumor necrosis or vascular invasion that would suggest that it is a malignant tumor. The Helsinki scoring system uses 3 parameters: mitosis more than 5 per 50 hyperfields, score of 3. Presence of necrosis scored as 5, and they use a numeric value for Ki67 proliferation index. And in this system, when you have a score of more than 8.5, it suggests that the tumor is malignant, and a score of more than 17 predicts an adverse prognosis. So this system incorporates both diagnostic algorithm as well as prognostication. The definition of microinvasion is tumor cells that invade through a vessel wall and form a thrombus or fibrin tumor complex, or an intravascular tumor cells that are admixed with platelet thrombus or fibrin. So we know now that microscopic angioinvasion is also a prognostic factor in adrenocortical carcinomas. With regards to IHC and molecular biomarkers for ACC, the 2022 WHO emphasizes the importance of an accurate assessment of proliferation rate. And this includes the mitotic count and Ki67 index. So if you noticed from all the previous criteria, the mitotic count that has been one of the criteria is if it is more than 5 per 50 hyperfield. So this indicates that there is an increased mitotic activity. With regards to the grade, they have subdivided ACCs into low grade and high grade ACCs depending on number of mitosis. Less than or up to 20 mitosis per 50 suggests that it is a low grade ACC, whereas if it's more than 20 mitosis per 50 hyperfield, suggests it's a high grade ACC. In patients with a low grade ACC, sometimes it's difficult to identify the mitosis, and in this situation, the IHC that is used is a phosphohistone H3, as seen in this photomicrograph. The slide above is a low grade where it's sometimes difficult to pick up the mitosis, and in that situation, we can use this IHC. Previously, we knew that SF1 is a diagnostic marker to tell you that it is a cortical tumor. If you want to know if it is malignant, the marker that has been shown to be of good value is the IGF-2. 4 prognostic markers include P53 and beta-catenin. Now, regarding the management, we know that as the stage increases, the prognosis worsens. For localized tumors, the treatment of choice is complete resection with R0 or negative margins, and this is the only chance of cure. The extent of surgery would include en bloc resection with periadrenal and hilar lymphadenopathy. In the metastatic setting, there is a role for debulking only in the subset of patients where there is severe hormonal excess that cannot be otherwise controlled, and about 80% of the tumor burden can be safely removed, or in a situation where there's perceived risk of local complication without other treatment options. Regards to the adjuvant treatment, mitotain has been universally given post-surgery on the basis of about 7 or 8 retrospective studies suggesting prolonged time to recurrence with mitotain. However, there have been conflicting evidence reported, and there is also challenges with administration of mitotain. So with this background, there was a trial between 2008 to 2018 that was specifically targeted to low and intermediate risk ACCs to evaluate the efficacy and safety of adjuvant mitotain compared to surveillance alone following complete tumor resection. And the findings suggested that there was insufficient evidence that mitotain efficacy and suggested that active surveillance is adequate for low-grade and localized ACC. Further, 2003, there was another trial, and this was aimed at advanced ACC to establish the treatment standard. When we say advanced, these are a subset of patients who are not amenable for surgical resection. This cohort was randomized into a group that had received etoposide, doxorubicin, cisplatin, and mitotain, and the other cohort was those that received streptozocin and mitotain. The group that received EDP plus M showed better response, significantly better response, better progression-free survival. However, there's no difference in overall survival. So from this, the current algorithm for management of resectable ACCs is that the low-risk group, that is the NSAT stage 1 and stage 2 with a Ki-67 less than or equal to 10%, active surveillance is adequate. The standard risk where the NSAT stage is 1 or 2 with a Ki-67 11 to 30%, or a stage 3, the Ki-67 less than 30 would benefit from adjuvant mitotain, and the rest would receive systemic therapy. Advanced and metastatic disease, the treatment of choice would be systemic therapy, first line being EDP and mitotain based on the previous trials, second line streptozocin and mitotain. The issues from these, of the issues that we know are that in localized ACC, after complete resection, the reported recurrence rates is close to 50%. Advanced metastatic ACC, the objective clinical response to the best available therapy is less than 25%. So therefore, there's an undeniable lack of efficient drugs for treating ACC and the need for identification of newer therapeutic agents. And therefore, there have been multiple clinical trials trying to find out what drug or the best drug for adrenocortical carcinomas. I've just listed out or shown a couple of trials. This set of trials was done on the IGF and the mTOR pathway. And as you can see, there's a very dismal response. TKIs have also been tried. Again, the response has been dismal. This may be because mitotain induces CYP3A4 activity, which leads to rapid metabolism of some of the TKIs. And many of these trials have been performed on patients who are receiving mitotain as well. So recently, there was a trial with cabozantinib, and this was in a cohort of patients that did not or stopped mitotain for a considerable duration of time. And there was some evidence of response. So there are 2 ongoing phase 2 trials with cabozantinib, one in Europe and one in US. Immunotherapy has come in a big way in treatment of cancers. In ACC, in the tumors, we know that there is a low degree of T-cell infiltration and they are leukocyte deplete, maybe because of intratumoral glucocorticoid exposure. And there are 4 trials that have sort of looked into immunotherapy, again, with not very good responses. The molecular profiling of tumors, now this is just in the lab. It's not been translated to the bedside. We have categorized tumors into 3 risk groups or clusters, depending on the mutational pathways that have been seen, the RNA expression, the chromosomal landscape, and the DNA methylation. And these clusters are the cluster of cluster 1, which shows low disease progression rate, cluster of cluster 2 with an intermediate disease progression rate, and cluster of cluster 3, which shows a high degree of disease progression. So maybe the future would, we would see AI that is being used in the diagnostic workup, identification of markers to predict response to therapy, tumor sequencing, molecular profiling as the clusters has been shown may support therapeutic decision-making and identification of drug combinations with improved outcome. And screening and follow-up may be non-invasive techniques for early diagnosis and detection of recurrences. So just two readings that I thought would be good for the postgraduates if you have time to go back and read. Thank you.